Hi, everyone. Glad to have you with us and welcome. My name is Bill Callery. I'm Manager of Programs and Knowledge Exchange at the Chronic Disease Prevention Alliance of Canada, or CDPAC. For anyone who's not familiar with CDPAC, I'll tell you a little bit about us. We've been around for about 15 years, and we're a network of many of Canada's largest national health charities and professional organizations who've come together to advocate and share knowledge about research, surveillance, policies, and programs for promoting healthy living and preventing chronic diseases in Canada. To learn more about CDPAC, you can check out the website and social media listed at the bottom of the slide, and you can find as well past webinars and upcoming webinars linked from our website. So today's webinar is a collaboration between CDPAC and the Canadian Institute for Health Information's Primary Care Information Program. It's entitled Primary Healthcare in Canada, Highlights from CIHI's 2016 Primary Healthcare Chartbook and Future Directions. We're extremely pleased to be co-hosting this webinar with CIHI, which is going to profile and highlight results from CIHI's recently released report called Primary Healthcare in Canada, Chartbook of Selected Indicator Results. It'll provide reflections from a population health and health systems perspective and present information on related guidelines from the Canadian Task Force on Preventive Healthcare and their application to clinical practice. So on behalf of CDPAC and our co-host, the Canadian Institute for Health Information, I'd like to wish you a warm welcome and thanks very much for joining us. I'm really pleased to present our first presenter, Tanya Khan. She's the project lead with the Primary Healthcare Information Program at the Canadian Institute for Health Information and our co-host for this webinar. She's an epidemiologist and leads the analysis and reporting team on a wide range of analytical projects, including the development of pan-Canadian indicators for performance measurement in primary care. Since joining CIHI in 2010, she's had the opportunity to work with various teams from across the organization, such as the Quebec Analytical Team and Portal Services. So at this point, I'm going to hand it over to you, Tanya, to introduce our other presenters.
Okay, thank you very much, Bill, for the introduction. So on behalf of CIHI, I just want to welcome you all to today's webinar that will focus on different aspects of performance measurement in primary healthcare. We really hope that today's presentations will be informative and help launch or continue the dialogue around performance measurement in primary healthcare. So I'm just going to introduce our other speakers that we have today. So we're delighted to have Dr. Ivy-Lynn Bourgeault and Dr. James Dickinson today with us to present. So Dr. Bourgeault is a professor in the Telfer School of Management and the Institute of Population Health at the University of Ottawa and the Canadian Institutes of Health Research Chair in Gender, Work, and Health Human Resources. She's also the scientific director of the Pan-Ontario Population Health Improvement Network and the Ontario Health Human Research Network, which are both housed at the University of Ottawa, and they are funded from the Ontario Ministry of Health and Long-Term Care. Dr. Bourgeault also leads the Pan-Canadian Health Human Resource Network with funding from Health Canada and CIHI, and she has been a consultant to various provincial ministries of health in Canada, to Health Canada, and to the World Health Organization. And her recent research focuses on the migration of health professionals and their integration into the Canadian healthcare system. So thank you, Dr. Bourgeault, for joining us today. And we also have Dr. Dickinson, and he's been a professor of family medicine and community health sciences at the University of Calgary since 2002. He's a family physician with a special interest in screening and preventive care, especially related to cancer and immunization. He's worked in medical schools in Australia, where he worked on his PhD on preventive activities in general practice, and in the Department of Health in Canberra, as well as Hong Kong. So he's been involved in the development of screening in these countries relating to cervical screening policies, and has also, since returning to Canada, been involved in efforts both in Alberta as well as participated on national committees. He also runs the Alberta surveillance system for influenza and participates in research about effectiveness of immunization. So welcome, Dr. Dickinson. So before I get into the presentation, I just wanted to provide you with a brief overview of CIHI for those of you that may be unfamiliar with the organization. So CIHI is an independent, not-for-profit organization that provides essential information on Canada's health system and the health of Canadians. So our goals are threefold. So it's to be a trusted source of standards and quality data, to expand our analytical tools to support measurement of health systems, as well as to produce actionable analyses that will accelerate improvements in population health outcomes and health system performance. We aim to achieve these goals by focusing on various activities that are outlined in our new strategic plan. So the new strategic plan that began in 2016 goes until 2021, and it outlines our renewed direction to help transform and accelerate improvements in healthcare, health system performance, and population health across the continuum of care, including primary healthcare. So details on our new strategic plan are available on our website, so www.cihi.ca. So I'm just going to delve right into the focus of today's presentation. So just going to skip ahead. In April 2016, CIHI launched the Primary Healthcare in Canada. It's a chart book of selected indicator results. So during today's presentation, I'll be providing you with some background on the chart book, highlight some key indicator results, and discuss how data gaps are going to be addressed as we look to future work in the area of health system performance. And as Bill mentioned, we'll have a few minutes at the end of the presentation for some questions. So just getting into some background, as we all know, measuring performance of the health system allows us to target opportunities for improving patient care and to enable high-quality care delivery. So this also applies to primary healthcare, which is the most common healthcare experience by Canadians. So one of CIHI's goals is to establish new pan-Canadian data sources and information that can be used to better understand primary healthcare across Canada, report on primary healthcare indicators, and inform health policy and decision-making at all levels. So accordingly, the main objective of our chart book is to provide detailed indicator results for a select group of indicators that are reportable at a pan-Canadian level. So we focused on presenting results with breakdowns over time by age, gender, as well as by province, territory, and even region when possible. So the main chart book report, along with companion methodology notes and Excel data tables that contain expanded indicator results, are publicly available for download on CIHI's Primary Healthcare Information webpage. So this chart book focuses on the results of 16 of 51 indicators outlined in CIHI's 2012 Pan-Canadian Primary Healthcare Indicator Report. So these 16 indicators were selected from the 2012 set based on data availability and quality, data that allowed for trends over time and breakdowns by geography, age, and gender, as well as the ability to adhere to the 2012 Pan-Canadian Indicator Technical Specifications without needing major modifications. And these indicators were derived from a range of data sources, including data holdings that are available at CIHI, as well as survey data that is available from other organizations such as Stats Canada. So the 16 selected primary healthcare indicators included in the chart book were organized according to the relevant domains of CIHI's Health System Performance Measurement Framework. So CIHI released the Health System Performance Measurement Framework in 2013 in an effort to help provide a common understanding of different performance assessment efforts being undertaken across Canada. So the framework is composed of 4 interrelated quadrants: health system inputs and characteristics, social determinants of health, health system outputs, as well as health system outcomes. So you'll note here that the 16 primary healthcare indicators included in this chart book fall into 3 of the quadrants. So the health system inputs and characteristics refer to the relatively stable characteristics of the health system. So for the purposes of the chart book, there were 3 primary healthcare indicators that fell into this quadrant: family medicine physician supply, registered nurses or nurse practitioners employed in a primary healthcare setting, and uptake of information and communication technology in primary healthcare. So the social determinants of health include both structural and intermediary factors. So structural factors are those that influence health, that shape individuals and family socioeconomic positions, such as income, social status, education, and literacy. So biological, material, psychosocial, and behavioral factors are collectively referred to as the intermediary determinants of health. And there are interrelationships among these intermediary factors, as well as between the intermediary and structural factors. So there are 3 primary healthcare indicators relating to behavioral factors that were included in our chart book: smoking rate, fruit and vegetable consumption rate, physical activity rate during leisure time, and there was also 1 indicator characterized as being both biological and behavioral, so overweight and obesity rate. So lastly, the 3rd quadrant is the health system outputs category, and these are services that are delivered that result from activities undertaken by the organizations and individuals that are part of the health system. So it describes the characteristics that contribute to the overall quality of the services. So there are 2 indicators relating to access that were included in their chart book: population with a regular medical doctor, as well as difficulties obtaining after-hours primary health care. There are actually 7 indicators that fell under the umbrella of appropriate, effective, and safe. And I'll just quickly list them out: smoking cessation advice from a regular medical doctor, eye exams in adults with diabetes, influenza immunization for seniors, colorectal cancer screening, cervical cancer screening, ambulatory care sensitive hospitalization rate, as well as medication lists in primary healthcare using a computerized system. So I'm now going to provide you with an overview of select indicator results and focus on aspects related to chronic disease prevention and management. As I mentioned before, additional information on the indicators, as well as the full chart book, are available on CIHI's primary healthcare information webpage. So as we've been looking at the indicator results by focusing at the prevention of chronic diseases, let's start off with examining smoking rates and smoking cessation advice. So we all know tobacco is a leading preventable cause of many diseases, including chronic diseases such as chronic obstructive pulmonary disease. So the role of primary healthcare in promoting smoking cessation is critical to reducing the morbidity and mortality associated with this risky behavior. So as you can see in the line graph, the rates of smoking in Canada have significantly decreased since 2010. In 2014, roughly 18% of Canadians aged 12 years and older reported daily or occasional smoking, and significantly higher rates were reported for men than for women. Smoking rates also varied across the country, with the highest rates being observed in Nunavut with 62%, and the lowest rates observed in BC with 14%, and these numbers are from 2014. So in terms of smoking cessation, less than half of current smokers reported that they had received smoking cessation advice from a regular medical doctor in the past 12 months, which indicates that there is potentially some room for improvement. However, it's important to note that this indicator is based on survey data, and there was only data available for 4 provinces. So CIHI also recently released a report on trends in income-related health inequalities in Canada. So the report examined inequalities in health by income level in the past decade. And in terms of smoking, the study found that most Canadians smoke less than they did in 2003, but that there was no change among Canadian adults in the lowest 2 income levels. So this information can help tailor prevention as well as smoking cessation strategies. So 2 other important preventative health measures are maintaining a healthy body weight and engaging in regular physical activity. So being overweight or obese is a risk factor for many chronic diseases. And it's also associated with certain psychosocial problems, functional limitations, and disabilities. So primary healthcare providers have a role to play in counseling patients about the associated health risks, and this is increasingly important as the rates of overweight and obesity continue to climb. So in 2010, since 2010, there's been an increasing trend in the rate of overweight and obesity in both Canadian youth and in adults. In 2014, 23% of Canadian youth aged 12 to 17 reported a height and weight that classified them as overweight and obese, with significantly higher rates observed in males than in females. In 2014, 54% of adult Canadians reported a height and weight that classified them as overweight and obese. And similar to youth, significantly higher rates were observed among males than among females. So a key factor in maintaining a healthy body weight and promoting good health is engaging in regular physical activity, and primary health care providers can play a key role in supporting patients to become physically active. So we found that in 2014, more than half of the Canadian population was moderately active to active during leisure time, and rates decreased with increasing age. And understanding these differences can help target the design of health promotion strategies. So now let's turn from preventative health measures to early detection. So certain types of cancer can be considered as chronic illness as they're ongoing and never completely resolved, similar to diabetes and heart disease. So based on Canadian cancer statistics, 42% of Canadian women and 45% of men will develop cancer during their lifetime. So there's a significant burden of illness. Colorectal cancer is the third most commonly diagnosed cancer in Canada. So screening tests such as the FOBT test and screening sigmoidoscopy or colonoscopy can help detect colorectal cancer before any symptoms develop. When the colorectal cancer is found and treated early, the chances of successful treatment are better. So primary healthcare providers play a key role in ordering these screening tests and in referring patients to specialists for screening colonoscopy and sigmoidoscopy. So this indicator was calculated in collaboration with the Canadian Partnership Against Cancer. So in 2012, 43% of the population aged 50 to 74 reported having undergone colorectal cancer screening, which, as I mentioned, either included either FOBT in the past 2 years and or sigmoidoscopy or colonoscopy within the past 5 years. Screening rates varied widely across Canada's provinces and territories, and the highest rate was observed in Manitoba, just under 60%, and the lowest rate was observed in Quebec at 27%. So another screening test aimed at early detection is cervical cancer screening in women. So cervical cancer screening with a Pap test can reduce the risk of cervical cancer by identifying the need for treatment before invasive cancer, cervical cancer develops. And similar to colorectal cancer screening, primary healthcare providers can play a key role in reducing the incidence of cervical cancer and its associated mortalities. So this indicator was also calculated in collaboration with the Canadian Partnership Against Cancer. In 2012, the national self-reported rate for cervical cancer screening within the past 3 years was 78% for women aged 20 to 69 years. And all jurisdictions had a cervical cancer screening rate greater than 70%. Influenza immunization is a preventative health intervention aimed at reducing the morbidity and mortality associated with influenza. So the people at the greatest risk of influenza-related complications are adults and children with underlying chronic conditions. And a large number of seniors also report having at least one chronic condition. So this group is at a higher risk of complications from influenza, and complications commonly such as pneumonia. So for this reason, NACI, or the National Advisory Committee on Immunization, recommends that at least 80% of eligible Canadian seniors receive the annual influenza vaccination. And primary healthcare providers are actually very well positioned to support their senior patients in obtaining their annual influenza immunization. So in 2014, 63% of Canadian seniors received the annual influenza immunization, and there were similar rates observed in both males and females. Additionally, rates have been relatively stable over the past few years. So now I'm just going to shift the focus of the presentation to look at access to primary health care, which is not only important for the prevention of chronic diseases, but it's also particularly important for managing care for persons who are living with chronic diseases. It's well established that access to primary health care is a hallmark of better health, lower total healthcare system costs, and increased continuity of care. So it's an important indicator of how easy it is for the population to interact with the healthcare system. So in the chart book, we included 2 indicators relating to access. The first indicator captures the proportion of Canadians aged 12 and over who report having a regular medical doctor. So as you can see, the percentage of Canadians reporting that they had a medical doctor was 85% in 2014. Rates have all been somewhat consistent over the past 5 years as well, and there was large variation noted across the country. And we've sort of expected to see this variation as we know that models of primary healthcare also vary across the jurisdiction, and we know that models of primary healthcare are not always physician-led models, especially in the more remote regions. So this is actually important to consider when interpreting indicator results. So the second indicator was derived from the Commonwealth Fund International Health Policy Survey of the general public. So since 2007, the percentage of Canadians reporting difficulty accessing medical care in the evenings, on weekends, and on holidays without going to the hospital emergency department has declined. However, more than half of Canadians still report access difficulties in 2013. So the next survey of the general population will be in 2016, and results are expected fairly soon. So we'll be able to see if there have been any improvements in after-hours access to care over the last few years. So related to access is having the right number and mix of primary healthcare providers. Primary healthcare delivery is primarily led by family medicine physicians or nurse practitioners in Canada, but there are also other primary healthcare providers that deliver care. So in terms of chronic disease prevention and management, these primary healthcare providers are often the first line of care for the prevention, detection, management, and treatment of chronic conditions. So today I just wanted to share two variations of the primary healthcare provider indicators with you. So one indicator focuses on the supply of family medicine physicians, and the other one looks at the number of registered nurses, including nurse practitioners who are currently employed in primary healthcare settings. So it's important to note that there's no ideal benchmark for the right number and mix of primary healthcare providers, and it's largely dependent on the jurisdictional context as well as prevailing models of care. So as you'll see in the line graph, over the last 5 years, the number of family medicine physicians per 100,000 Canadians has slightly increased, with 114 family medicine physicians for every 100,000 Canadians in 2014. So this roughly translates into 41,000 family medicine physicians. Of particular note, the supply of female family physicians is increasing at a faster rate than the supply of male family medicine physicians. So in 2014, there were 50 female family medicine physicians for every 100,000 Canadians, compared with 43 physicians in 2010. So another consideration in interpreting this indicator is that past research has found that male and female physicians practice differently, such that female physicians are more likely to restrict their practice during childbearing years. So the second indicator, provider indicator, is the number of registered nurses or nurse practitioners employed in a primary healthcare setting. In 2014, there were 67 registered nurses or nurse practitioners who provided direct care in primary healthcare for every 100,000 Canadians, compared with 70 in 2010. So this number has changed very little over time. So the last indicator that I wanted to highlight today is the uptake of information and communication technology in primary healthcare. So this refers to the use of electronic systems to enter and retrieve clinical patient notes and functionality such as reminders for patient care, warnings for drug interactions, interfacing with pharmacies as well as labs, and the ability to interface with other external systems. So the patient safety aspect of information and communication technology in primary healthcare may be especially important for patients with chronic diseases who may be taking multiple medications or have complex care needs. As you'll see in the graph, since 2007, the uptake of information and communication technology has significantly increased in Canada. So it's a good news story, with an uptake rate of 70% in 2014. So these findings, which were derived from the National Physician Survey, are consistent with findings from the Commonwealth Fund 2015 International Health Policy Survey of Primary Care Physicians. So now that we've examined a snapshot of primary healthcare indicators with a focus on chronic disease prevention and management, let's consider the implications for the future and areas of focus. So as you will no doubt have seen throughout this presentation, I'm sure that it's become apparent that there's still some gaps in pan-Canadian primary healthcare data. Calculations were possible for only a relatively small subset of the 51 indicators in the 2012 Pan-Canadian Indicator Report. and complete pan-Canadian survey data was not available for some of the indicators that I shared with you today. So continued efforts are required in improving the availability and quality of pan-Canadian primary healthcare data in priority areas. One avenue is to continue expanding primary healthcare data through patient-level billing, physician billing data, and making this available for cross-jurisdictional comparison. So in 2015, 2 provinces submitted their patient-level physician billing data to CIHI. So another central contribution is the increase of the primary healthcare electronic medical record content standards. And this will help improve the structure and quality of data, as well as research-based efforts that can be done to mine EMR data to better understand its full potential. So a last example is the continued development of data sources and measures related to patient experience and patient-reported outcomes, which are affectionately known as PREEMs and PROMs. So these measures are essential in improving our understanding of whether primary healthcare services make a difference to patients' health status and their quality of life. And they're also 2 important parts of CIHI's overall health system performance efforts. And CIHI is working closely with jurisdictions across Canada to better understand the need to measure these PREEM and PROM measures across all healthcare sectors, including primary care. So these are just a few examples of potential areas for expanding activity. So as we continue to build comparable pan-Canadian primary healthcare data, we also have to consider the indicators themselves and determine if they're still reflective of current priorities for primary healthcare performance measurement. So since we released the 2012 indicator report, the primary healthcare performance measurement landscape in Canada has continued to evolve in terms of primary healthcare measurement activity, policy themes, and research. And jurisdictional priorities continue to evolve over time as well. New and emerging data sources are increasingly being considered for indicator development, such as the patient-level physician billing data. And there are also some new primary healthcare indicators that are coming into the fold, such as third next available appointment, which can provide some complementary information on access. So our stakeholders from across Canada continue to emphasize and highlight the need for an increased focus on indicators related to the quality of primary care. So taken together, all of these points indicate that it may be timely to start thinking about updating the pan-Canadian primary healthcare indicator set with the goal of confirming indicators that align to current priorities across the jurisdictions. So thanks so much for your time. And before I open for a few questions, I just wanted to highlight some recent and upcoming CIHI releases. I won't go through them in detail, but all the information is available on CIHI's website. So I'll just hand it back over to Bill. Thank you.
Great, thanks very much, Tanya. Excellent presentation. We'll now take up to 5 minutes of questions from participants on the line. And we've got a few questions that have come in already. And anyone who's got any burning questions now, please send them in via the chat. So the first question from Mark Andrew is, do you have the number of family physicians per 100,000 for each province?
Yes. So thanks, Mark, for your question. And yes, we do have those indicator results broken down by province. So if you go into CIHI's primary healthcare information website, you'll see all the information available there for download.
Great. So unless there's any other questions, I think we'll continue on. And any other questions that come in, we'll answer them during the final Q&A at the end.
Wonderful. Thanks.
So, thanks very much. And I'll transfer control over to you, Dr. Bourgeau, so you can move ahead with your slides.
Excellent. Thank you. So I just wanted to really say thank you for the opportunity to provide some reflections on this really important report. And those reflections are going to be coming from my areas of expertise in terms of population health and also from a health systems perspective. So first of all, I really wanted to commend this report for situating these measures within a health system performance measurement framework. So it's really important to kind of tease apart what measures do we have for health system input, what are, the broader measures that we have for the social determinants of health, and then mapping that in terms of health system outputs, because all of these things are connected, but it's important to tease them apart in that type of framework. So the first set of considerations I would like to provide is just in regards to health system input considerations. And all of these comments are prefaced by saying acknowledging data limitations. So CIHI has a wealth of data, but there are some data limitations. And I wanted to point out a few of what those are because it's important to have that much more complete perspective, but it also gives an indication to CIHI about what areas might they be working on. So the first one is on family physicians and nurse practitioners. And often what we have are much better numbers on physicians than we do on nurse practitioners. So first of all, with respect to family physicians, it's really important for us to understand what we're measuring. And so when we measure numbers of physicians and we look at trends over time, that might actually be, we may not be measuring the same thing. We may actually be measuring apples and oranges, even though we're looking at family physicians in the year 2000 and family physicians in 2016. I'll just highlight, that there are some key gender differences that affect traditional measures of supply. There are gender differences, there are cohort differences that intersect with the gender differences. So as we have more women in family medicine, that will have an impact on the structure of family medicine work lives and family medicine careers. And so there's some good data coming out from particular provinces. Lindsay Hedden has looked at this in British Columbia, Sarah Simkin here in Ontario, that we need to take those things into consideration. So we need to be cautious about even interpreting numbers that are the same. Sort of also linking that a bit, sort of stepping ahead to comments around output, I think it's important to look at issues in terms of population access. So just in regards to outputs, it's important for us to also measure population access to primary care providers. So we need to include measures of nurse practitioners. And sometimes that can be difficult across provinces because the data may not be as robust as it is for family physicians. And even though nurse practitioners are a small profession, I think that we're getting into the area of 4,000 nurse practitioners, not all of whom are working in primary care, but I think that it's a number warranting for us to include that. It'd also be interesting to look at the activities nurse practitioners undertake in terms of activities like smoking cessation, obesity and overweight management, and also the different models of care that different health providers, primary care providers,
the conference.
So we'll have, family physicians and nurse practitioners. They might be working in family health teams with other health professionals. There might be nurse practitioner-led clinics, which, unlike what the name denotes, there are family physicians involved in that, but in a very different way than the way family physicians and nurse practitioners interact in family health teams, and community health centers, or the different varieties that there are, CLSCs in Quebec, community clinics in Saskatchewan, and how they impact on both access and supply. So the other issues in terms of health system input considerations is that there are other primary care providers in need of inclusion, and particularly for an audience like this in chronic disease prevention. What's the role of optometry and linking that to sort of measures of the output of eye exams? Pharmacists and their link to flu vaccines, because in many provinces they have that as part of their legislated activities. Also, what is their involvement in terms of management of medication lists? And again, that might link back to different models of care where pharmacists might be involved, for example, 1 day a week in family health teams and how do they manage some of these key chronic disease management activities. And in another profession, dietitians, and that, they're linked to overweight and obesity and other dietary-related conditions like diabetes. And dietitians have been a profession very understudied and also underutilized. We produce students and dietitians coming out, but they often don't get, referrals even in very promising interprofessional models like CHCs, family health teams, and nurse practitioner-led clinics. And these are things that we're starting to begin to investigate those. And that's also really important that it's not just uptake in the case of ICTs, but what their impact is. So, it's identified as an automatic good that healthcare providers are using ICTs, and there are important positive dimensions to their use of that. But it does have an impact on health workforce productivity, which in turn has an impact on supply and access. And there was some very interesting data coming out of the United States, which is a very different context, but nevertheless, sounding the alarm about how much time health professionals spend using ICTs. And so that is time spent away from direct patient care. And so are there different models of having ICTs, because they're really important, particularly from a research perspective, safety, performance measurement perspective, but, should we have family physicians do that, or nurse practitioners, should they be doing that, or should there be, another type of more assistant type of support around ICTs? So we need to examine both the uptake and impact, but also who has access to the electronic health record, which really has a major influence on interprofessional input into chronic disease management. So these are all some, additional considerations, and whether or not we have the data to assess this, is another set of questions. From a population health perspective, and I think really quite broadly in terms of population health, the social determinants of health measures that are considered here are important, but they're limited by the data sources. So again, I completely acknowledge that. Typically, when we look at social determinants of health and population health considerations, we look at those beyond the behavioral factors that are included here. So this is a typical model, Dahlgreen and Whitehead, who look at sort of broader work environment, education, living, working conditions, unemployment. And so these are some broader factors that can be taken into consideration for a fuller or more fulsome examination. And then again, issues in terms of turning back again to the issues of output. It's important to kind of situate that within what is now being referred to not so much as the triple aim, but the quadruple aim, is these intersecting improvements in population health, but also promoting health equity, and which is different from equality. So trying to really address those populations that may need additional programs, services, resources, and those with chronic diseases are indeed that group, as well as sort of improving quality and experience and reducing costs. And when we look at the issue of reducing cost, it's those notions raised earlier about productivity. How can we start to measure productivity so that we don't just assume that a physician is a physician is a physician, or a nurse practitioner is a nurse practitioner is a nurse practitioner. And it leads to issues around optimization, because troubling data coming from the OECD, and CIHI contributes data to the OECD, that a large number of tasks undertaken by, and they were only looking at this in terms of physicians and nurses, but this is, this is quite endemic across all health professions. I've mentioned dietitians before. Is the lack of optimization of their skills, that they're doing many activities that are below their skill level, and that to really reduce costs and improve access and quality, we should have health professionals working to what people refer to as the top of their license, optimizing their scope, their expertise, their skills and experience, and then optimizing that in working together in interprofessional teams. So those are just some additional considerations that provide a little bit more context to this really important report that really is moving the bar, that much further. My job is just to nudge even in further directions with the hope that we can pull together data, comparable standardized data across the different jurisdictions that start to measure some of these broader issues that reflect the complexity of our system. So with that, I'll pause and see if there are any questions.
So Bill here. I don't see any questions at the moment, but let's continue on. Thanks very much, Dr. Bourgeau. That's really helpful extra context to this. And at this point, I'm going to move ahead the slides and then pass it over to Dr. Dickinson.
Thank you for the opportunity to discuss this issue. And thanks also particularly to CIHI for this chart book on a very challenging topic. And I'd also like to thank Kaylin Kretschmer, who helped me put together the slides for this and the ideas that we have. The Canadian Task Force is a group funded by the Public Health Agency of Canada to produce evidence-based practice guidelines, and it's done at arm's length. The contract is actually through the University of Calgary, so that many people ask, are we just doing the work of government? Well, yes, in some ways, but fundamentally we are independent. The members are volunteers with expertise in primary care, prevention and methods, and about half are practicing family physicians. And we take conflict of interest very seriously, and each time we have a meeting we have to update our conflict of interest declarations and when people have conflicts of interest, they are removed from that particular discussion and decision. And the purpose is to develop and disseminate clinical practice guidelines. So the ones that we are working on, we use a variety of methods that are standardized across each approach, looking at the data to try and work out what's the right answer. And we use what's called the GRADE method, which is a Canadian-derived and developed system of grading of recommendations, assessment, development, and evaluation. And that helps to improve clinical care. It's used by clinicians and patients, also researchers and policymakers. Then this method fundamentally assesses the quality of the evidence, which unfortunately is not always very good. We have to make decisions sometimes on quite low level evidence, using evaluation of the study design, the potential for bias, the directness, consistency, and the precision. And perhaps different from previously, we're looking at evidence on the harms and the benefits. So previously, these sorts of discussions have tended to focus only on benefits. Does this activity work? Does it reduce deaths? But now we're also looking at how much harm does it create on the way to get a balance to help make better decisions. We also look at evidence on the values and preferences of the population, individual patients and families who are going to need to use this evidence. And we look to some extent at evidence on resources to make sure the intervention is a wise use of resources. Unfortunately, that's not always the case in the field of prevention. And the types of recommendations, and I've used here a sort of traffic light system. The traffic lights, green go and red stop. So we have strong recommendations in favor of an action, weak recommendations in favor, weak recommendations against, and a strong recommendation against. I hope that helps people to think through what's going on. The implications are, if it's a strong recommendation, we can make policy, we can really decide to do it or not to do it. We can expect that most people will agree, and so we can have high adherence, and obviously that's worth measuring. If it's a weak recommendation, there's a balance in there, and that requires consideration, individualization, and different people will make appropriately different decisions. So we're going to get variable agreement adherence, and so therefore there's an uncertain value of measuring, because it might be appropriate for maybe only 70% of people to do something where there's a weak recommendation for it. And then, of course, when we've done these guidelines and we've written them up, we disseminate them. We disseminate them through articles in the CMAJ as the first primary thing. But then on our website, you'll find a series of materials to help people to understand and to use those guidelines. Now, these are the list of published guidelines, and I'd just like to focus today on two of these that match up with what's in the Chartbook. And it will also mention the prevention of tobacco smoking, because that's coming and it also is in the Chartbook. So let's look at screening for cervical cancer, which I was deeply involved in. And the task force conducted a systematic review of the evidence as it was in 2013 and made recommendations for screening of asymptomatic women who are or have been active. And it's very important to note there's groups of people who don't belong, for whom these recommendations are not appropriate because they're in a different category. That makes it difficult in the Chartbook, of course, because largely we're looking at total population. And in the recommendations, the task force said, a red, don't do screening under the age of 20. Orange, don't routinely screen 20 to 24. Yellow, a weak recommendation in favour of screening from 25 to 29, but then a strong positive for women 30 to 69. Then those over the age of 70, if they've been adequately screened, they can stop. If they haven't been adequately screened, then it's worthwhile just checking on them before putting them in the no need to screen group. Now, you can find more information on the website and the full guideline. Obviously, I've just given a very brief summary. Now, the indicator that's used is the proportion of women 20 to 69 who self-report having undergone screening tests. One of the difficulties is that provinces and territories have varying target age ranges. So, in particular, it's unfair to add this one. BC and Alberta in 2016 have moved their age to 25 to 69. But of course, only those who are really sexually active and those who haven't had a hysterectomy. So the Chartbook has a simplified indicator. It's only an indicator. We've got to recognise that there are issues in using that indicator. But I would suggest, though, the indicator needs to focus on the strong recommendations for and against. So that's where we should be moving in the future, to look at the strong recommendations for, and also to measure inappropriate screening. Maybe the amount of screening under the age of 20 is an important one to measure, because there is unfortunately quite a lot of that. Now, for screening for colorectal cancer, we did a further systematic review, and again we made recommendations for a group where that's relevant, and a group we identified some for whom that is not an appropriate approach. And our recommendations were to screen between 60 to 74, and our recommendations tend to be on the conservative side, so using fit tests every 2 years or endoscopy every 10 years. As you can see, we have a weak recommendation about screening age 50 to 59, and some weak recommendations about not screening those over 75, and perhaps not using colonoscopy. And again, you can look at the more details on our website, looking at the guideline and the review and how we came to those decisions. Now, the indicator looks at the average risk population 50 to 74, and it uses one that matches the fecal occult blood test and one that's, again, slightly different, screening colonoscopy, sigmoidoscopy in the last 5 years. So, again, this is a difficulty of matching the real-world data that we have against the recommendations that we've made. For tobacco smoking in children and adolescents, we are still developing that. It's going to be on recommending how to go about doing prevention and treatment interventions. And so the indicator is a percentage who've been advised to get smoking cessation advice, and I hope that they're going to be a match. Though, of course, at the moment, we're simply looking at children and adolescents. We'll get on to adults later. Moving to another topic altogether, because this was also in the chart book, was the electronic medical records, where the task force is working on trying to help get the guidelines and KT tools into the electronic software programs. And it's not as easy as first thought. So we're starting with the breast cancer screening guideline and putting it into OSCAR, which is one of the major EMR tools being used in some parts of this country. So we're going to start pilot implementation and evaluation, and we'll go on from there. So really what we're trying to do is to make it easier for people, for primary care providers across the country to use the guidelines and the KT tools, particularly, that's to help teach patients and the population about what our recommendations are. And it'll also enable the providers to access the guidelines straight from the individual record. So we hope that we'll be able to take the information in the record, about the age of a patient and various other characteristics, so that the relevant guidelines only are going to be displayed. And then we can see whether that actually makes a difference. It's been released on a mobile app, which has been downloaded a reasonable number of times. We'd like to see more. And then the indicator, of course, is going to be the percentage of family physicians who use electronic systems. At the moment, it's referring to entering and retrieving patient notes and these other ones, and we hope that use of guidelines will be one of the things that can be measured. So, how are these indicators relevant? Well, successful implementation, we hope, will improve patient outcomes. We've got to have reliable indicators to see what's going on in practice, but we need to measure both the positives achieved, and in general, we tend to measure what people do. We don't measure quite so well when we're overdoing things, and that's something we need to start looking at more carefully, and we need good data to do that. So there are a lot of challenges. One of them is that while the task force makes a national recommendation, each province guards its own right to make its own recommendations, and the guideline committees in different provinces sometimes take note of what we've said, other times they go off in a different direction. It's difficult to get the data, and we really do, as I said, need to get reliable indicators to measure whether clinicians are de-adopting screening practices. PSA screening, which we recommend strongly against, clinical breast examinations, which aren't terribly useful, and, as I said earlier, Pap testing in teenagers. That will, of course, make the CIHI Chartbook even more complicated than it is at the moment, so it's not going to be easy. So we need to also develop indicators because, particularly for weak recommendations, the issue is, do clinicians discuss with patients what their values are and their ideas and what's the right decision for them? That's a really hard thing to measure, but that's what we need to be moving to. So really, it's a jungle out there. What do I mean by that? Well, primary care in particular is what I think economists call a multi-product firm. Sort of like a department store or maybe a general hardware store, as distinct from a specialist like plumbing or a paint shop or whatever. It's easier to measure when there's a limited set of products being produced. When you've got thousands of different products, it's very hard to measure. And primary care definitely is a multi-product output, and so it's a really difficult task to measure it. So there's even difficulties that we've seen here where we take just a specific field like prevention. So it's hard enough just in one field. Those difficulties are multiplied when we look across all the different fields within what primary healthcare does. But I really do like the fact that we've started. We're trying to get somewhere with this, because if we don't measure, then we really don't know what we're doing. So thank you very much for your attention. I look forward to questions.
Thanks very much, Dr. Dickinson. So it's Bill here again. We'll give up to 5 minutes of devoted question time for Dickinson, and then we'll move into our open question. And I think we probably about 20 minutes for that as well. So a few questions have come in already for you, Dr. Dickinson. One from Mark Andrew. He says, should cancer screening indicators be modified to take into consideration people who make an informed decision not to undergo screenings, even if they are recommended, considering that individuals may reasonably judge that the risks are not worth the benefits for them?
Well, I think, Mark Andrew, you're absolutely asking the right question. And you'll see, if you look at the task force recommendations and our discussion of them, that's exactly what we're recommending. That even for the strong recommendations, we still point out that some people may look at the evidence for and against and say, well, no, not really, that's not for me. And so, yes, for many of these, the really important thing is to measure that discussion, but that's really hard to do. The outcome, which is whether an activity happens or not, like for in breast cancer, mammograms being ordered or not, that's easy to measure. Whether those women who have the mammograms ordered were just told you should have a mammogram, or whether it's actually an informed decision, much harder, but I agree with you, it's actually much more important.
Thanks for that. And another question from Maureen. She asks, should we be measuring when we offer screening rather than patient uptake of screening?
In general, the answer would be yes. The question is how to do it, and that would really require doctors entering that information in their medical records, and then some way of extracting that from those records right across the country, or alternatively asking the patients when they have these activities, were they fully informed? Either way, it's not going to be easy to measure.
Interesting. Okay, so I don't see any more questions coming in specifically for Dr. Dickinson. So I think we'll move into our open question period at this point. We've got up to about 20 minutes, and there's still a few questions that were remaining for Tanya. So maybe I'll switch gears over back to you, Tanya.
Sure.
Question coming in asking how to increase the percent of Canadians who had a regular medical doctor, and do you have a recommended size per physician?
So that's a great question, and I think determining the right mix and supply of different primary health care providers is certainly important to planning effective primary health care services and quality health care services. So CIHI doesn't have a recommendation in terms of panel size, but I think it's a potential area for future research that would certainly be helpful.
Can I just make a point there?
Absolutely.
Right number does depend on what you want your primary care physicians to do. If you just want primary care doctors to refer patients appropriately to the right specialists, then you can have a very large panel. If you train your family physicians so they can do quite a lot of areas within each special area, for example, can they treat skin cancers? If they can, then there's far fewer referrals to dermatologists. Can they look after people with cardiac failure to a certain extent? Reduce the number of referrals to cardiology. Depending on how much we expect family physicians to do, then the panel size will change substantially. And that also depends on the level of training that we give to family physicians. At the moment in Canada, it's not a very high level, unfortunately. It may be more efficient if we had more training and therefore less need for referrals, in which case the panel size would be different.
Yes, Dr. Dickinson, I think you raised an excellent point that optimizing the different scopes of practice among the different primary healthcare providers is certainly something that we need to consider.
Yeah. And at the moment, that's mostly been done from the point of view of the professionals. We should be looking at it, what would the patients prefer?
Great. Well, the next question from Jim, and I think this was directed to you, Tanya, but the other presenters may have comments as well. Jim asks, what is CIHI doing to get physician-level data and addressing your other future wish lists?
So thanks, Jim. That's an excellent question. So the physician information team here at CIHI, as well as our client affair managers across the country, are discussing the potential of patient-level physician billing data being submitted to CIHI for other jurisdictions as well. And we've done some analytical projects using the patient-level physician billing data, such as an analysis looking at continuity of care. And we use data for 2 provinces for which CIHI has this data, just to showcase some of the potential uses of this emerging data source. So there's definitely activity looking to build some pan-Canadian data.
Thanks, Tanya. Comments from Dr. Bourgeau or Dr. Dickinson?
Yes, well, I think it's absolutely critical in terms of getting these data, and what CIHI has been working on is sort of a minimum data set, not just for physicians but other health professionals, and that's really building off of, but not exclusively, a minimum data set project that they have ongoing in Ontario. So it's a requirement of regulations that the regulatory bodies provide this minimum data set upon registration. And so it's called the Health Professions Database, and it includes, I believe, 59 items that really help you identify sort of workforce characteristics, how much you're practicing, are you specializing in particular areas, geography, gender, other issues like that, for all, 23 to now 26 regulated health professions. So CIHI has identified what's the minimum data, what are the minimum questions that we need to ask health professionals, and then let's do that in a coordinated fashion across the different provinces. Now, medicine, for whom we have the highest quality data, but the Scots Medical Database that CIHI, doesn't somehow house, but, analyzes the data from, they don't have a complete minimum data set for that. And so there's a project working with the different medical regulatory authorities to collect that. Some of the other professions are further ahead, midwifery, for example, but CIHI doesn't sort of house midwifery data, but it is comparable across the different jurisdictions. It's a much smaller profession. And so the different professions are at different stages of this minimum data set in order for us to be able to say that whatever measure they're using in Quebec is the same that they're using in Saskatchewan, and then we can do some much more robust analyses of the type that I was suggesting for us moving forward. But there's only so many hours in the day, and this is a lot of work, and you're dealing with a lot of different organizations, and CIHI has been excellent in doing that, but significantly more resources would need to be put into this, but it's critical because this is from my perspective, and I appreciate, I do work on health workforce, but, our health system is our health workforce, and it's what they do, and it's the activities that they undertake and how they work together, and if there's anything to dedicate resources into, it's this.
Yeah, it's a very difficult topic, and the trouble is the field is moving as we speak. So that, for example, in primary care, we're now developing many sort of specialoids within family medicine. So many people may register as family physicians, but they're actually doing maybe full-time or 50% palliative care or sports medicine or something else. And so, at what point are they no longer really part of the primary care workforce? Very difficult to work out these measurements. I don't envy the people who are doing it.
No, absolutely, I agree. And so that's why it's important to interpret, these data with some caution. So, for example, the student colleague that I mentioned, Sarah Simkin, who's using data in Ontario, using measures that at ISIS, the Institute for Clinical Evaluative Sciences, and the primary care research group within ISIS has identified as how do you identify who are the physicians or health providers who are providing comprehensive primary care. And don't quote me on the exact numbers, but the last conversation that I had was that really 80% of the family physicians who are licensed in the province, according to this measure, are providing comprehensive primary care. So that's why we need to not only have the numbers and how many per population and where they're distributed and all that kind of stuff. We need to know, are you providing, comprehensive primary care? And we can draw upon these data to be able to answer these questions.
Thanks for that. The next question from Carrie Ann. She's asking about whether, Tanya, you can explain why the number of physicians would differ between 2010 and 2014.
Sure, and I think she had some questions in terms of the data limitations. So all of the indicator technical specifications are available for download in the companion methodology notes. So I can get back to you with some caveats around the indicator calculations, but just briefly, the accuracy of the number of active physicians depends greatly on the validity of the physician's mailing address for the purposes of calculating this indicator, and that there could be some undercoverage issues when physicians work in locum positions since they change locations frequently. And in the Scots directories, you can't add locum physicians to its active physician group, given that there's a bit of insufficient information on them.
Tanya? Next question is, on slide 14, could you provide some context for why access to a regular medical doctor appears lower for the territories as compared to other provinces?
Sure. So the territories have different models of primary health care that tend to be more nurse practitioner or registered nurse-led rather than just solely physician-led. And this is definitely a caveat to keep in mind when interpreting this indicator. And I think we've touched on it previously too, that scopes of practice are different as well in the territories in terms of primary care. I don't know if Dr. Bulsho or Dr. Dickinson had any other additional comments.
Yeah, so I can speak to that issue. And again, it's about sort of the different numbers. If I'm understanding that question correctly, I mean, there's an increase in number of family physicians, but again, depending on how they practice, going back to some of these issues, that Dr. Dickinson and I have raised, some may not be providing, comprehensive care, so that might shift, so the numbers change all the time in terms of there's increased output from the medical schools. Like we have never produced as many students or as many physicians as we have historically. That's starting to taper off, but so there's increased enrollment, increased graduates. There are increases in the international medical graduates that are graduating. But even though there are increased numbers, it may not translate may or may not translate into, comprehensive provision of services. It depends on how they practice. I'm not sure if that gets at that question, but that's a little bit more of the nuance. These are all of the issues that make it so challenging. I really I don't envy the folks at CIHI, in pulling these data together, and then the interpretation has to be done with such caution. So you absolutely need the data, but you have to realize, that there are limitations to the data, and there are other sources of evidence that we need to get beyond just the quantitative data.
It's awfully complicated. Next question from Marcy is regarding the data on the percent of Canadians who had a regular medical doctor. Has any research been done with those who do not to look at reasons why?
So that's an excellent question, and I don't believe as part of the Canadian Community Health Survey, which is the primary survey that we used for many of the primary healthcare indicators included in the chart book, I don't believe that there was any questions looking at reasons why Canadians would not access a regular medical doctor. So I think it would have to rely more on the qualitative research for that. So I don't know if Dr. Bourgeau or Dr. Dickinson, you have any comments to add there?
Certainly, I'd agree that, particularly for healthy young males, there's really little need for a regular medical doctor. So it's not entirely surprising that many of them don't have one. That varies. If you're chronically ill, yes, you do. For many women, there is a need, depending on what their life situation is, there is a need for a regular doctor. But for many young women also, they really don't have any specific need for that sort of relationship, and so it's not surprising if they don't. It's more concerning when you have someone who has chronic illness or other healthcare needs if they're not able to get somebody. So again, any indicator is only a snapshot, but we need to understand what the reality is on the ground to try and understand what the right answer should be.
Well, and the other limitation that we need to take into consideration with the Canadian Community Health Survey is that they don't cover any people's in First Nations communities, so on reserve. And so it's, and particularly, that's particularly problematic when we have the Truth and Reconciliation Commission calls for action, which is to focus on the population health and social determinants of health of Indigenous Canadians. That's another important limitation. So that might actually be an underreporting of the lack of access.
Well, we're getting to the last few minutes of the webinar, so and I have one more question. But if anyone's got any burning questions, please do put them in the chat. The final question I've got here is, are results available for all 51 of the primary healthcare indicators developed in 2012?
So I guess that question is for CIHI, so I'll take a stab at answering that one. So I'll just say that the 2012 CIHI report focused on putting together a set of priority primary healthcare indicators, and there were broad stakeholder consultations that were undertaken to ensure that the indicators reflected important aspects of primary healthcare, but this was just a priority set. So it didn't take into account actually feasibility of calculating. So as you will see, what we tried to do with the 2016 chart book, we focused on putting together a feasibility set or calculating indicators based off of this 2012 priority set. And data was only available, quality data was only available for 16 of the primary healthcare indicators. So we've still got a ways to go in collecting primary healthcare data.
You've heard from Tanya Khan talking about the results from CIHI's Primary Healthcare Indicators Chart Book, Dr. Bourgeau about providing additional context from a population health perspective, and Dr. Dickinson on related guidelines, indicators, and KT tools from the Canadian Task Force on Preventive Healthcare. I hope you found this interesting. Thanks very much to our presenters, absolutely, for sharing your work and your knowledge with us today. and I want to make sure to thank everyone in the audience for their insightful questions and participation, hanging in there for an hour and a half. And I think with the final few minutes we've got left, I'd love to hear final words from our presenters. So I'll start with you, Tanya.
Great. So thanks everyone again for participating in today's webinar, and I really hope it's the start or the continuation of a dialogue to look at performance measurement in primary healthcare. And I just invite you to email us any comments or questions. As well, CIHI will have a booth at some upcoming conferences this fall, and I would very much welcome the opportunity to continue at one of these conferences in person. So the Canadian Health Workforce Conference will actually be taking place next week, October 4th and 5th in Ottawa. CIHI will also be at the Health Quality Transformation Conference in Toronto on October 20th, the Ontario Hospital Association Health Achieve Conference in Toronto in November, as well as the Family Medicine Forum coming up in Vancouver as well in November. So thanks again.
And your final thoughts, Dr. Bourgeau.
Well, first of all, let me thank Tanya for doing the shout out for the conference that we're organizing next week, the Canadian Health Workforce Conference. So we will be presenting, some more issues around primary care. The two people that I mentioned, Lindsay Hedden will be presenting her data there. From British Columbia, Sarah Simkin will be presenting her data here in Ontario. I believe they will both also be at the Family Medicine Forum. So we also try to, we're an unfunded research network, so we're trying our best to be at as many places as we can. And so we do try to get to those professional association conferences as well. And I look forward to any feedback that folks have about health workforce issues, big and small. And I really appreciate having the opportunity to present today.
Thanks very much. And Dr. Dickinson, last but not least.
Well, thank you for the opportunity to take part in this. And I do think that getting more sophisticated about measurement is the way forward. It's going to be really difficult, as I said, because if we're trying to measure what's really happening in primary care, and we should be trying, it's going to be difficult because it is trying to be all things to all people. And so it has so many different components, each of which is worth measuring. For example, inappropriate or appropriate antibiotic use, and so on. Trying to measure across all of those fields is a really difficult job. But we've got to keep trying to get better at this.
Well, I'd like to, again, say a huge thanks to our audience, and hopefully we'll see you and connect with you at upcoming events and potentially webinars. And just thanks again, and hope everyone has a great rest of their afternoon.